Well, thank you very much for this opportunity, Josh, Farr, Ashley, Lydia, for this invitation to be with you all. It was about last November, Farr and I initially began conversing about coming and sharing some of the work I'm doing locally at Duke on the project on the Good Surgeon. I think you'll find this next hour to be much more pragmatic, practical, pedagogical. But in order to get us there, I do want to do some analytical work, stepping back and looking at discovering, to use Ashley's quote from the introduction, discovering the ways that we're being shaped and the environmental hazards that we must steer around, paddling up the river towards a more hopeful medicine, a more hopeful surgery. So thank you for the opportunity. It was the middle of my intern year. I was on a typical 30-hour shift on the acute care surgery service, frequent consults, trips back and forth to the emergency department, multiple cases in the operating room, non-stop nursing pages. I was on call with Michael, one of our senior residents who was in his second to last year of training. And about 2 a.m., he called me down to the operating theater to hold retractors on a difficult gallbladder. During the case, my pager was buzzing constantly with pages from the cardiac intensive care unit. So as soon as we finished the case, I quickly called the number back, and the nurse who answered ushered us quickly to the unit. As we entered the ICU, I immediately noticed 20 to 30 people gathered outside a particular room. Nurses, respiratory therapists, pharmacists, even a chaplain, which we all know is an ominous sign. The code cart was inside the room. However, everyone was very casually talking, leaving the room, kind of quiet amongst themselves. Now, the attending intensivist saw us and quickly walked over. He apologized for the many pages during our case, thanked us for coming. The patient, after undergoing a difficult cardiac operation earlier that day, had developed dead bowel ischemia from poor perfusion, which was making him septic. However, between the initial page and us arriving in the intensive care unit, the patient had coded and died. They couldn't get him back. The intensivist thanked us and said our services were no longer needed. So we left. Back in the elevator down to the emergency department, Michael declared, "Thank God he died. We've had a busy enough night." Now, the comment certainly caught my attention, struck me as cold, but we were beyond exhausted, and I just needed to move on to the next task. We made it through the rest of the shift and signed out at 6 a.m. to the team who would take over for us. Michael asked if I wanted to grab a quick breakfast in the cafeteria before we left to get some sleep. And as we were eating, he paused, looked up at me, and for a brief moment confessed, "Ryan, I can't believe that I was actually glad, relieved really, that a man died last night so I didn't have to deal with yet another case. What the hell has happened to me? Why am I even doing this?" He paused. We finished breakfast and we left. The conference prompt asks how good physicians, good surgeons are made and lost. Now, the empirical literature paints a pretty dire picture. Surgeons are not flourishing. Most recent data demonstrates that approximately 20% of surgical trainees leave surgery altogether after only a single year of training. And their mentors are equally disillusioned. When social scientists asked a representative sample of surgeons in the United States whether they wished their children would pursue a career in surgery, half said no. In the same study, 40% met criteria for burnout, 30% screened positive for depression, 28% reported low mental quality of life. Surgeons are not flourishing. In this paper, I want to argue along with the late medical sociologist Charles Bosk that surgical training is primarily a moral education. Surgical trainees are moral agents, and the activities they practice habituate what they come to see as true, good, and beautiful. Through training, we learn what is worthy of attention. In fact, surgical training is all about attention, and this is even found in our vocabulary. At the end of surgical training, if successful, one becomes an attending surgeon. But this, of course, begs the question, attending or present to what or to whom? In his confession over the breakfast table, Michael was attending to whom he was becoming. Now, he was horrified with the result of that formation, but for a moment he was able to pause and reflect. How many other residents go about their work inattentive to the ways in which they're being shaped to see, to attend to the world? Now, much as the medical education literature has been written about the idea of the hidden curriculum, the incongruencies between, on one hand, what is taught in the lecture halls, found in the ancient codes, or perhaps found in modern mission statements. And this is compared to the actual day-to-day practices of modern medicine. I'm not so sure hidden is the correct adjective anymore. No one disputes this, and patients are certainly in the know. Patients report feeling like broken cars waiting to be fixed in the factory of industrialized medicine. A busy resident like myself or Michael in our story, caring for 30 or 40 patients. It's no wonder that our grammar quickly and infrequently inhabits that of depersonalization, referring to the new admission as the gallbladder in room 6. And accounts like this are prevalent. So what were the habits and environmental hazards that were shaping Michael in ways that were incongruent with who he thought he was and what he thought were the virtues of a good healer? What led him to question whether he even belonged in medicine? Now, Western medicine, according to anthropologists Byron Good, prioritizes the technical and subverts the metaphysical. Modern medicine, in so doing, has adopted a soteriological function. Good writes that sickness, death, and finitude are found in the corpse, in the human body, and salvation is present in the technical efficacy of medicine. The technical has come to categorize and control birth, health, illness, suffering, and death. Furthermore, the commodification of modern medicine has transformed medicine into what a colleague at Duke University, behavioral economist Dan Eyerly, calls a fixing people production line. Thus, the dominant logic of medicine has become oriented towards market utility and shaped by its defining metaphors: safety, efficacy, timely, cost-effectiveness. Health economists, our administrators, frequently cite, for example, the Toyota production system, or even Atul Gawande, we were just speaking about at lunch, famous essay on comparing medicine to the Cheesecake Factory. These analogies of these different institutions prioritize quality and efficacy while trying to minimize error. Attention in surgery. Modern surgery, so conceived, requires a finely tuned attention to symptoms and anatomic variants, mechanical application to problems. I need to be able to recognize the subtleties of an acute abdomen, identify the common bile duct amidst inflamed tissue, and safely and effectively remove a necrotic gallbladder, all while avoiding injury to surrounding structures. In 1890, William James defined the form of attention that has come to characterize modern surgery as, quote, the taking possession by the mind in clear and vivid form of one out of what seems several simultaneous possible objects of trains of thought. It implies withdrawal from some things in order to deal effectively with others, unquote. Ultimately, this form of attention stems from a Baconian, Cartesian understanding of humans as potential masters and possessors of nature. Illness is something we fight, we seek to conquer, and attention is the primary means of redress. Now, this form of attention is not easily acquired, Surgery deals with much more than mere knowledge. The medical student may have an accurate understanding of anatomy and physiology that is engendered by interacting with neatly drawn diagrams in textbooks or even the cadaver, but this is hardly sufficient for surgery. In the operating theater, nothing looks quite like the drawings. Surgical trainees need to learn how to translate this knowledge into real and difficult clinical contexts. In the operating theater, there are countless things I must immediately and simultaneously attend to. The patient's heart rate, blood pressure, where to make my incisions, how the patient responds to insufflation, if the stomach is properly decompressed, if my medical student has figured out how to get his gloves on and on. However, I quickly withdraw from these things when I see they're normal so that I can attend specifically to the inflamed gallbladder. For I must carefully and meticulously identify and protect the key structures. This requires the ability to see the body in a way that depends on James' notion of attention. Now, with any virtue, the surgical trainee acquires this ability to see through repeated practice and activity. Over the course of 5, 7, or up to 10 years of apprenticeship, young surgeons, through the practice of attention, begin to see what they previously could not. However, having acquired the ability to see the anatomy and pathology, surgery next involves the application of mechanical interventions. The mechanics, cut, tie, dissect, sew, also occur within the world of sight. It is only through attention that one gains the ability to see and feel where to cut, tie, dissect, and sew. That is to say, in the operating room, attention is an intellectual virtue, something to be cultivated. As hexis, it is an active holding forth in the soul, and once habituated, it is like unto a second nature. It's difficult for me to explain to, say, a new trainee how much tension is required to properly ligate a bleeding vessel with a silk suture. Too much tension, you'll tear through the vessel, resulting in even more uncontrolled bleeding, not to mention many expletives from your attending. Too little tension and you'll fail to ligate it, resulting in bleeding perhaps now or hours later when the suture further loosens. When I ligate the vessel, I just feel and sense when the tension is right. I can't really describe it. It's just that I've ligated vessels many, many times before. Although it is immensely difficult to acquire both the anatomic and technical virtues proper to surgery, there still exists a hierarchy of the virtues, and these are merely the lower rungs of the ladder. These necessary but lesser virtues are directed and informed by prudence, and this is where the crux of surgical education lies, the development of prudence, of sound judgment. It lies in knowing whether even to intervene in the first place, when to intervene, and which intervention minimizes the individual patient's risk. Like the ability to see the anatomy or feel the proper tension to ligate a vessel, prudence is gained only by experiential learning cultivated through repeated embodied practices within particular communities. And surgery is one such community. New surgeons come to embody the practical wisdom of the surgical tradition by dwelling within it. For example, as an intern at the Mayo Clinic, I was on the service of a famous liver surgeon. I remember a clinical encounter with a patient who had traveled literally hundreds of miles for what would be her third and final opinion. The master attending reviewed her blood work and scans with the patient. Then he gently held her hand and told her he would not operate. He told her she should instead spend her remaining time with her family and her loved ones. Now, during my time on his service, I watched him perform operations that literally only a handful of surgeons in the entire world are able to perform. And yet I'll never forget that he also knew when we should not proceed. For Joseph Pieper, prudence was the first of the cardinal virtues because prudence directs and molds the other virtues. He writes, "None but the prudent man can be just, brave, and temperate, for the good man is good insofar as he is prudent," unquote. For prudence animates and engenders the other virtues. It is the, quote, cause, root, mother, measure, precept, guide, and prototype of all ethical virtues. It acts in them all, perfecting them to their true nature. All participate in it, and by virtue of this participation, they are virtues, unquote. Thus, the practice of medicine that attends to the anatomical and the technical is brought into a fuller reality when directed and guided by prudence. But if we stop there, we risk becoming myopic, blinding ourselves to the deeper reality that unfolds in the operating theater, which is wrapped up in and with and under the patient. For James' notion of attention, which seems to enable surgery in its modern form, requires that we necessarily withdraw from some things in order to attend to others. So we gain the ability to see the anatomy, pathology, to perform the mechanics, even to exercise the prudence necessary for the art. But what is lost in the midst of this attentive gaze? From what have we withdrawn? I believe the answer is twofold. We withdraw from the ability to attend to ourselves, and ultimately we lose sight of the patient. First, attention to self. The world of surgery is fast-paced. The demands seem infinite. We move quickly from patient to patient, task to task, often with no time to eat, much less for the difficult work of discovering who we're becoming and the habits that are shaping us in various directions. Just as we learn to be attentive to the anatomical and to the practices, the habitual acts that are shaping who we're becoming, so too we must attend to who we are being shaped into. While surgical education has focused primarily on efficient technique, I believe that a deliberate inward attention to one's moral formation is necessary to withstand the environmental hazards of modern commercialized medicine. And second, we lose sight of the patient. Modern surgery, and particularly procedural specialties like surgery, are frequently subject to critique for failing to develop the skills and traits to attend to the patient as person, as theologian Paul Ramsey has it. Jamesian attention has too narrow an aperture to behold the patient. It doesn't surprise us that many patients thus report feeling dehumanized when caught up in this sort of vision. In order to see the patient as person, as a unique, whole individual, not a composite of broken parts to be fixed, we must be brought up into or enraptured into love. For attention is the substance of love. For Simone Weil reminds us, quote, not only does the love of God, which has attention for its substance, the love of neighbor, which we know to be the same love, is made of this substance. Those who are unhappy, she writes, have no need for anything in this world, but people capable of giving them their attention. The capacity to give one's attention to a sufferer is a very rare and difficult thing. It is almost a miracle. It is a miracle. Medicine needs to make space to cultivate these forms of attention to who I'm becoming, and attention to the sufferer, the patient as person. So how might we ameliorate this corrosion? One local attempt at Duke University in collaboration with some friends at Wake Forest is the Project on the Good Surgeon. Working through a curriculum of medical humanities, philosophies of medicine, as well as sociological critiques, the project will cultivate a space for friendship and mutual accountability, where difficult questions are raised and new habits and practices are formed, alternative modes of attending. This course will be piloted both at Duke and Wake Forest this upcoming academic year. And our pilot leverages existing infrastructure in the lab years following the second clinical year of training. So during this time, our residents are freed from their clinical duties to focus on their research, productivity, which are required, at least in the States, to secure faculty appointment in academic surgery. These lab residents have experienced firsthand the challenges of practice, but have the time to step back and construct habits to meet the challenges that are no longer merely abstract, but have become concrete in their daily practice. The hallmark of the program will be a series of 9 small group dinners, structured by a formal curriculum of readings, both ancient and modern. Deep discussion over a shared meal at a faculty member's home in an unhurried fashion demonstrates hospitality, humility, lessens the academic hierarchy, thus fostering a thick moral community. In addition, we will facilitate engagement with the humanities, guided tours of museums, which we'll hear about a little bit later, group attendance at theater, sketching the human form with an artist, different activities to develop new habits, new ways of attending and self-reflecting. Thus, a resident like Michael will have been formed in such a way to see clearly the environmental hazards of modern surgery, the work hours, the exhaustion, the patient load driven by profit margins, the ways we're prone to vice, greed, tendency to depersonalize our patients, but also to be reminded of his calling and the virtues necessary to sustain such a call. Our aim is to cultivate not just technically proficient surgeons, but good surgeons. By way of example, I'll end with a poem by Auden. We are at Oxford, after all. But this demonstrates the sort of work I seek to do with my trainees. Auden shows us that poetry can cultivate attention to indifference and suffering. In this poem, the plowman sees something amazing, but carries on with routine. Throughout training, suffering has become routine to my residents. Their emotional responses are dulled. Perhaps this numbing is what lets us carry on in our day-to-day, a protective mechanism, no doubt. Yet residents need to periodically be reawakened and attend to patients as persons, for no human is routine, no suffering is routine. The last stanza from Musée des Beaux-Arts. In Bruegel's Icarus, for instance, how everything turns away, quite leisurely from the disaster. The plowman may have heard the splash, the forsaken cry, but for him it was not an important failure. The sun shone as it had to on the white legs disappearing into the green water, and the expansive, delicate ship that must have seen something amazing, a boy falling out of the sky, had somewhere to go to and sailed calmly on. Thank you.